Hello, everyone, and welcome to today's webinar, Monkeypox Epidemiology, Clinical Features, and Diagnostic Testing. I am Megan Pascal of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Seegene Technologies. To learn more, visit seegenetech.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. I'd like to now welcome our speaker, Dr. Matt Binnicker, Director of Clinical Virology and Professor of Laboratory Medicine and Pathology at the Mayo Clinic. Dr. Binnicker, you may now begin your presentation.
Thanks for the introduction. Thanks everybody for joining me today for this update on monkeypox. As you probably have seen in the news, monkeypox was recently renamed by the World Health Organization to MPOX. That is the new name for the disease. There still is a chance that the virus name will be updated as well, but I'm going to be referring to monkeypox as MPOX per the updates from the World Health Organization over the course of this presentation. So we'll be talking about the epidemiology of MPOX, the clinical features, and how we should go about testing for this disease in the clinical laboratory. Also, before I begin, want to thank LabRoots for putting on this and coordinating this webinar presentation, and for Seegene for sponsoring the event. Also, just to disclose some conflicts of interest, I am an advisory board member for DiaSorin Molecular and Mammoth Biosciences, and I've received honoraria for several educational presentations from the companies listed below. So we'll go ahead and dive into the presentation. And, it's been a rough couple years for all of us. 2020 was difficult with stay-at-home orders and the COVID-19 pandemic. 2021 really felt like it was going to be the year where we were going to pull out of the pandemic. Vaccines were available. And I've heard from many that it felt like 2021 was going to be the time when we were jumping out of the burning building into the arms of safety. Unfortunately, 2022 rolls around and we continue to have surges of COVID-19 in certain parts of the country, a influenza outbreak now that we haven't seen the likes of in years. And of course, who would have thought a monkeypox outbreak? And so instead of falling into the arms of safety, in some ways it's felt like we have bounced into another burning building. But I'm hopeful that 2023 is going to hold a lot of promise, and hopefully will be much quieter for all of us. So the objectives for today's presentation is I'm going to walk you through some key epidemiologic features of MPOX, and we'll try to highlight why the current outbreak of this viral infection is unique. It's not the first outbreak, but it definitely is unique as we contrast it with other outbreaks that have occurred over the past few decades. We'll try to draw out and describe the clinical features of MPOX disease, and I'll highlight why this is a challenge for our providers and physicians because of the variability in clinical presentation that's being seen in this particular outbreak. And then finally, I'll point out the different laboratory methods that we have in our diagnostic toolbox that can be used to assist in the diagnosis of this viral infection, and talk about how we can use those laboratory methods along with the clinical presentation to help establish a diagnosis of MPOX infection. But before we do that, I wanted to start with a patient case, and this is a case that we actually encountered at Mayo Clinic earlier in 2022. And I think it's a really good example of the type of clinical presentation, of applications of various laboratory methods, and definitely underscores some do's and don'ts when we encounter a suspect monkeypox case. So, as is usually the situation, it's a Friday afternoon at 3 p.m. when the laboratory staff here at Mayo Clinic give me a call, and they indicate that they have an odd viral culture result that they'd like me to come down and take a look at. And yes, Mayo Clinic at the time was still performing viral cultures. We've since discontinued viral culture testing of respiratory samples because of the COVID-19 pandemic, and dermal and genital samples because of the ongoing monkeypox outbreak. But at this point, the lab saw this odd viral culture result and wanted me to come down and take a look. So I went down to the lab, and they showed me this image that's projected on your screen. So in our laboratory, we would inoculate two different types of eukaryotic cells with samples from patients. One is cells derived from Rhesus macaques' kidneys. So these are primary kidney cells, and the other cell lines are a human Medical Research Council 5 or MRC5 cells. And so what we're seeing here are the Rhesus monkey kidney cells 3 days after being inoculated with a fluid from an anal lesion swab. And what you can see, hopefully on this image, are there areas where it looks like the cells are rounding up, other areas where you can see more spindle-shaped cells, but really focus in on those refractile, rounded up cells that, to our laboratory staff, were concerning for some type of a viral infection. What we would do in this type of a situation is, after those initial cells showed that cytopathic effect, the lab staff would then passage those cells into fresh, uninfected Rhesus monkey kidney cells. And this is what we saw in those passage cells. So about 24 hours after the passage was completed, we saw more progressive cytopathic effects, so more areas of involvement. And you can see now at around the 7 o'clock position, a nice cluster of rounded refractile cells that are kind of grouped together. Another example about the 12 o'clock position. And this was definitely of concern for our laboratory staff. But you might be asking, why was this a concern? Why wouldn't this just be considered a normal viral culture finding? So this was a red flag for a few reasons. First and foremost, the cytopathic effect that I showed you actually resembled what we would see with another common viral infection called adenovirus. So when we see adenovirus grow in eukaryotic cells, the cytopathic effect that occurs is described often as grape-like clusters. And so if you remember back to the prior two slides, you could see how there were areas that could be described as clusters of grapes. However, the laboratory thought of this, and they did a quick direct immunofluorescence test on the viral culture for adenovirus, and that was negative. So that really ruled out adenovirus as the cause of what we were seeing. Second, we saw more rapid growth in those Rhesus monkey kidney cells compared to the other cell line that we inoculated, which is those Medical Research Council 5 or MRC5 cells. And so when we see better growth, more cytopathic effect in one cell line versus another, it can give us an idea of what viruses may be causing the infection versus what viruses may not be present. And then finally, the specimen type that was sent to us. It was an anal lesion swab. And so when our laboratory receives certain sample types, they're able to put together a list of potential suspect viruses. And from a dermal genital lesion swab, we usually would grow herpes simplex virus. That's by far and away the most common virus that would grow from that type of a specimen. But if it would have been HSV, the cytopathic effect would have been as pronounced or probably more pronounced in the human cell line than in the Rhesus monkey kidney cell line. So for those reasons, the laboratory flagged this as a bit abnormal and wanted me to come down, take a look, and provide some feedback. So after seeing the microscopy results, walking back to the office, I knew that I needed to get some additional information on this particular case to really be able to determine what the possible viral infections were in this instance. I was able to get that information pretty quickly, and the specimen had been sent to us from the state of Arizona. The patient is a 29-year-old male, HIV positive. And the clinical records indicated that this individual had a new sexual partner 2 weeks prior to the sample being collected. About a week after his last sexual encounter, he developed a pruritic pustular lesion on his inner thigh, and he also developed a headache and body aches. So when the patient's symptoms first began to appear, he was evaluated at a county health department sexually transmitted disease clinic. And at the STD clinic, the patient was tested for chlamydia, gonorrhea, and syphilis, all typical STDs that might be causing these types of symptoms. And the testing for those infections came back as negative. I mentioned that this patient was known to be positive for HIV, but at the time of presenting to the county health department STD clinic, his HIV viral load was undetectable. His CD4 count was marginally low, but not extremely low at 480 cells per cubic millimeter. And without a defined diagnosis, this individual was treated empirically with ceftriaxone, azithromycin, and penicillin. He was also started on valacyclovir for possible HSV infection. But the individual's symptoms didn't really improve over the following week. And because of that, he decided to present to his local emergency department. So when he was examined in the emergency department, he was found to be afebrile. He had normal vital signs, denied a sore throat, didn't have any neck stiffness, no nausea, vomiting. Notably, he did have a palpable right inguinal lymph node. So just file that away as interesting information that there was an enlarged lymph node in his groin. He also had this papular lesion on his inner thigh. He also had developed recently a raised anal lesion that was described as papular, and I'll show you that on the next slide. So here are the images that were taken in the emergency department. So on the left-hand side, you can see the remnants of this inner thigh lesion. Definitely not something that would stand out as significant, but because he had had this over the course of the last week, week and a half, it was photographed. More pronounced was the anal lesion, which had been present for only a few days, and you can see that on the right-hand side of this slide. So the physician in the emergency department felt like this was likely a diagnosis of molluscum contagiosum because of the umbilicated appearance of that anal lesion. So if you're not familiar with molluscum, here's an image of what molluscum contagiosum can appear as. So you can see why the emergency department physician might have thought that this was molluscum contagiosum, because you see that indented, umbilicated appearance of the lesion, as we saw on this patient's anal lesion. Now, what happened was that the physician requested a swab of that anal lesion be collected and that it be sent in for viral culture. And unfortunately, no other microbiology studies were ordered. No bacterial cultures, no molecular studies for other viral pathogens. And the patient was discharged from the emergency department and instructed to complete his 7-day course of valacyclovir. So you might imagine that as I'm gathering this information, I'm getting more and more concerned, because this is around July of 2022 as we're beginning to hear reports of increasing numbers of MPOX infections in the United States. This is the right patient, the right clinical presentation, negative studies for other infectious diseases like chlamydia, gonorrhea, syphilis. And I'm really thinking this could be MPOX. Now, interestingly, our laboratory had just finished validating a real-time PCR test to detect MPOX virus just the day before. And so after reviewing the patient's medical records, I talked to the lab and said, why don't we go ahead and take this sample and have it tested by our MPOX real-time PCR, just to be sure that it's not MPOX. Well, 4 hours later, I got a knock on my door, and of course, the result was positive for MPOX virus. So this was a case of MPOX, and it's probably the first time in my career that the first actual clinical sample that's tested by a new assay turns out to be positive for the virus that we're looking for. But that's just how the last few years has gone. So we're going to talk more specifically about this virus and its epidemiology and the varied clinical presentation that we can see. So this is an enveloped virus, and it possesses a DNA genome. And you can see a really great image provided by my friend and colleague, Ryan Relic, on the right-hand side of what this virus looks like. It's a member of what's called the orthopox virus genus. And the orthopox virus genus consists of other viruses such as variola, or the causative agent of smallpox, as well as camelpox, cowpox, vaccinia virus. MPOX virus was first identified in the late 1950s during an outbreak of a pox-like illness among monkeys that were being used for research studies. And that's really how this virus got it the original name of monkeypox virus. It wasn't until 1970 that the first recorded human case of MPOX virus occurred in the Democratic Republic of the Congo. And so we've known about MPOX virus in the human population for over 50 years. But as we'll point out, there's something very different and unique about the current ongoing outbreak of this virus across the globe. So historically, this virus has been considered a viral zoonosis, which is endemic to the Democratic Republic of the Congo in Africa. We don't know exactly what the natural reservoir for the virus is, but there is some data suggesting that rodents and non-human primates are the likely natural reservoir for where this virus resides before it crosses over into the human population. There are two phylogenetically distinct clades of MPOX virus. The first, which was previously referred to as the Congo Basin or Central African clade, has now been renamed or reclassified as Clade 1. And the second, which was previously referred to as the West African clade, is now referred to as Clade 2. These two different clades carry with them different disease severity. So the Central African Clade 1 has a mortality rate approaching 10%, whereas the Clade 2 virus has a mortality rate of around 1% or less. And fortunately, it's the Clade 2 virus that's the causative agent of the ongoing outbreak worldwide. And that is why, fortunately, we're seeing to date relatively low numbers of deaths due to MPOX virus infection. So prior to this year, outbreaks of this virus outside of endemic countries in Africa have been extremely rare. And the outbreaks that have occurred have been associated with contact with animals from Africa or travel to Africa. Now, there has been a large outbreak in the United States prior to this current outbreak, and that occurred back in 2003. But the scale was dramatically different. In 2003, there turned out to be 47 confirmed cases. And the investigation that occurred during that 2003 outbreak showed that those who became infected all had contact with pet prairie dogs. And it turned out that initially there was concern that the prairie dogs were reservoirs for MPOX virus. But it was determined that those prairie dogs were being housed in the same facility in cages near other small mammals that had been imported from the continent of Africa, and specifically Ghana. And the animals were the giant African pouched rat, which you can see on the right-hand side of your slide. And what was determined to be the case was that the giant African pouched rat had been infected with MPOX virus and then infected the prairie dogs, which were then purchased and taken home as pets, and they then caused crossover infection into the human population. So I was able to get a few images from actual skin biopsies from the 2003 outbreak from my colleague Bobby Pritt. And it's interesting to look at the pathology of what's occurring in an MPOX virus infection. So you'll see that at the top of these images are areas of clearing of the cells or edema. So this is basically where fluid is filling these areas and causing these opening areas where there should be dermal cells. And this is actually where the vesicles would occur over the course of the next few days if this were allowed to progress. So this is, again, fluid-filled vesicles resulting from MPOX virus infection. The other thing that I'd point out is if you look at areas where there's darker staining, that's usually in histopathology, areas that we want to focus in on. And if we zoom in on those darker staining areas, you can see that there are some multinucleated cells. And also I'll point out what's referred to as an intracytoplasmic inclusion, which is described as a Guarneri body. It was actually a description made by an Italian physician, Dr. Guarneri, who showed that these intracytoplasmic inclusions can be common in patients infected with MPOX virus. So the 2022 outbreak. The first case was detected in early May of this year, and it was an individual who resided in the United Kingdom and had recently returned from travel to the country of Nigeria. As of a week ago, there are now over 80,000 confirmed cases globally. The United States is leading the way at close to 30,000 confirmed cases, Brazil at over 9,800 cases, and Spain at approaching 7,400 cases. We're seeing MPOX virus in 110 countries, the majority of those being in areas where MPOX has been considered non-endemic, so in areas where we haven't seen this particular virus causing outbreaks in the past. 55 total deaths to date, 12 in Brazil, 14 in the United States. So again, in comparison to what we've experienced with the COVID-19 pandemic, the number of total deaths is relatively low, but still 55 total deaths worldwide from the current outbreak is something for us to keep a very close eye on. So I've been asked many times over the last few months, why are we seeing an MPOX virus outbreak in 2022 to this scale? This is really the first time that we've seen an outbreak of MPOX virus with wide transmission outside of Central and Western Africa in many nations around the world. In the past, all of the prior outbreaks have been associated with contact with an animal from Africa or travel to the continent of Africa, and that is not something that is associated with the current outbreak. The current outbreak actually is mainly associated with close, intimate contact resulting from person-to-person spread of the virus. And because of the scale of infections and the number of countries involved, the World Health Organization declared this a public health emergency on July 23rd of this year. So the CDC and the World Health Organization are actively studying the virus that's in circulation. And to date, there hasn't been results based on sequencing that would show that there's a significant genetic difference in the currently circulating strain that would account for an increased transmission rate or a reason why the outbreak is occurring now. In other words, there doesn't seem to be anything genetic about the virus, the current virus, that would explain why we're seeing an outbreak in 2022. There are some likely explanations. The first and foremost is the decreasing population level immunity to smallpox. So many of your parents, grandparents, great-grandparents were vaccinated against smallpox virus. And you'll remember that smallpox is a member of the orthopoxvirus genus, and there's cross protection of smallpox with MPOX. And so smallpox has been eradicated now, and so there's a decreasing number of people across the globe who are receiving smallpox vaccination. So we have declining levels of immunity to that virus, and therefore declining levels of immunity, cross-protective immunity to MPOX. We're also seeing today more global travel than ever before. So a virus in one corner of the world can reach any area across the globe in less than 24 hours. And the mode of transmission that we're seeing with this particular outbreak, along with personal behaviors, I think these are all contributing to this large worldwide outbreak of MPOX virus. So in terms of different modes of transmission of the virus, we already pointed out that in past outbreaks, it usually resulted from direct contact with an infected animal. And in the continent of Africa, this is typically how an MPOX virus outbreak initiates, is someone from a community comes in contact with an infected animal, and that can result then in crossover into the human population and typically controlled or small levels of transmission within the community. What we're seeing now, though, in this particular outbreak is large levels of person-to-person spread, primarily through direct contact with an infected lesion. And most, not all, but most cases in the current outbreak have resulted from sexual transmission. There are a few other routes of transmission that are possible. One that we've learned a lot about over the past few months is the possibility that the virus can be spread through contaminated fomites. And fomites are inanimate objects such as bedding, towels, unwashed clothing that if an uninfected person comes in contact with, can actually cause a transmission event. And there's been a number of really nice studies now looking at detection of MPOX virus on fomites. And these studies have shown that the virus can persist for weeks on porous material like towels and clothing. The virus can be recovered in cell culture. PCR studies have shown that the DNA from the virus can be detected for weeks. And so this is one possible route and has been shown to be confirmed as a route of transmission in a small number of cases during the current ongoing outbreak. Finally, there's been some talk about whether MPOX virus can be spread through the respiratory route. I'll just say it's a possibility. Not likely, but a possibility. And if it were to occur, it would most likely require prolonged face-to-face exposure in the range of several hours of time for an infected individual to be able to transmit MPOX virus to an uninfected person through respiratory droplets. I'll just say that if respiratory transmission was a predominant mode of transmission, we wouldn't be talking about 80,000 confirmed cases. We'd be talking about 8 or 80 million confirmed cases of MPOX virus. So I don't think that this is a predominant means of transmission. So in terms of clinical features, on average, the mean incubation period is around 7 days. It can occur as soon as 3 days after exposure or as long as up to 3 weeks, but on average, it's about 7 days. The clinical presentation that we're seeing during the current outbreak is a wide distribution of clinical manifestations from extremely mild to severe. The initial symptoms can involve fever, chills, headache, body aches. Usually a rash develops 1 to 3 days after an individual develops a fever. And remember when we were talking about the patient case, that the patient developed an enlarged lymph node in his groin, and lymphadenopathy is a key distinguishing feature from smallpox. So in patients who had smallpox, we wouldn't see enlarged lymph nodes, where it seems to be more common in patients with MPOX virus. Now, a challenge associated with the current outbreak is that varied clinical presentation. 6 months ago, if you had been asked what MPOX looks like or how a patient would present, you would probably describe something like the image on the right-hand side of the slide, a patient with hundreds of lesions that were characteristic and not typical of other infectious or non-infectious causes of skin lesions. Unfortunately, this is not the presentation that most patients are presenting to emergency departments and clinics with. Instead, these are the types of lesions that patients are presenting with. You can see a wide distribution in the appearance of these lesions, from what looks like a pimple on the fourth image from the left, and then on the thumb on the far right-hand side, that may be similar to a lesion that might be found on a young child that has hand, foot, and mouth disease caused by Coxsackie virus. So this is what is a challenge for physicians who are seeing these patients, is it doesn't always stand out as something that could be MPOX virus. It could be some other infectious cause of the lesion, and in some cases may even look like a pimple or something that's non-infectious. So I'm sure that there are situations where patients present with MPOX virus lesions that are determined or thought to be due to something else, and testing is not performed, as was the case in the patient case that I described. So with regards to diagnostics, it's really a combination of exposure history, the clinical presentation, and laboratory confirmation. As I highlighted in our patient case, this virus will grow readily in eukaryotic cell lines, with a cytopathic effect appearing on average in about 2 to 3 days after inoculation. Now, just because the virus will grow well in eukaryotic cell lines doesn't mean that we want to order viral culture. In fact, viral culture should not be ordered in cases of suspect MPOX virus infection, and that's because cultivation of this virus in culture represents a safety hazard to our laboratory staff. Instead, we have good molecular tests available now that can detect MPOX-specific or non-variola orthopoxvirus DNA in specimens like dermal and genital lesions. So with regards to collection of samples for diagnosis of MPOX virus infection, the current recommendations from the Centers for Disease Control are to submit 2 swabs, either dry or in viral transport media, from 2 to 3 suspect lesions. So why would we want to collect swabs from several different lesions? And it's because patients may present with lesions that appear differently. Some of the lesions may not be due to MPOX virus, whereas others might. And so getting a collection from at least 2 to 3 different lesions increases our probability of detecting an individual who's infected with MPOX virus. There was a really great study that was published a few months ago comparing different specimen types in patients with MPOX virus. And the data really showed clearly that swabs of the dermal or anogenital lesions is by far and away the best specimen type for detection of MPOX virus. The virus can be detected from other sites and sample types, including the nose and the throat, the blood, urine, and semen, but at much lower rates than the lesions of the skin and genital tract. So we've talked briefly about safety precautions for laboratory staff. And when our laboratory staff are working with samples from suspect MPOX patients, if they're working with non-lesion specimens such as urine and blood, those sample types can be worked with using standard precautions in a biosafety level 2 environment. And those staff who are, again, working with urine blood-based samples don't need to be vaccinated against MPOX virus. Lesion samples are a bit different, and it's recommended that when possible, staff be vaccinated against smallpox, MPOX, and that can provide an additional layer of protection for those laboratory staff. For non-immunized staff, the CDC recommends to use BSL-2 precautions with special practices or BSL-3-like practices, and I'll go into a bit more detail on this slide. So in those situations, what we want to do is have our laboratory staff working with samples inside of a Class 2 biosafety cabinet. They should be wearing a solid front gown with cuff sleeves. They should be double gloved and wearing eye protection or a face shield. If they're going to be performing any aerosol generating procedures, such as vortexing a tube that's open, an N95 respirator is recommended, but I'll say that that probably isn't being done in most laboratories. Just recommending not to perform aerosol generating procedures and having those samples being worked with inside of a Class 2 biosafety cabinet with the other measures listed here on this slide. In terms of vaccination and treatment, there are 2 vaccines available for prevention of MPOX disease. The Jynneos vaccine is approved for prevention of both MPOX and smallpox and is the vaccine that's being used most predominantly across the United States. There is a second vaccine listed here that's approved for prevention of smallpox, but it has been made available for immunization against MPOX under an expanded access IND. The Jynneos vaccine is given via an intradermal injection, similar to a TB skin test. And the vaccine could be administered pre-exposure, or if someone has been exposed to someone who may have MPOX, the vaccine can be given as a post-exposure prophylaxis to help prevent disease onset. There's also an antiviral called TPOXX, which was approved for treatment of smallpox, but is being used in some cases of severe MPOX disease. And I'm sure we'll begin to see more data come out on the efficacy of TPOXX treatment for treatment of MPOX. So I want to wrap up just with some future considerations and unanswered questions regarding the current outbreak. I'm often asked, will this virus be contained and will it completely go away in developing nations in the United States? And I really think at this point it's unlikely to be completely contained and go away. We are at over 30,000 confirmed cases of MPOX virus infection in the United States. And my guess is there are many undiagnosed cases out there that aren't recognized. Is it going to become an endemic disease? In other words, will we be detecting MPOX virus in the population in the future? And I think that answer is likely. This virus is probably at this point well entrenched in the population, and outside of a global vaccine campaign against the virus, I don't think that the virus will completely be eradicated in the 110 plus countries that have now been confirmed to have this virus. And will we be testing for the virus in the future? And I think that is likely to be the case. In many patients who are being worked up for other sexually transmitted infections such as HSV, syphilis, we may need to test for MPOX virus alongside other what we've considered more common causes of those STI infections. Here's just some data on the positivity rates, both nationally and what we're seeing at Mayo Clinic. So over on the right-hand side of the slide are data from the Centers for Disease Control. And you can see that in July, the positivity rate peaked out at around 50%. But you can also see at that time that the number of tests overall being performed was very low. As testing expanded, we actually saw the positivity rate start to decline, but it's really plateaued over the course of the last 3-4 months at around 20-25%. If we look at our specific data at Mayo Clinic, our October positivity rate for monkeypox was 29%. Now, I just want to compare and contrast that to some other common sexually transmitted infections. Our historical positivity rate for chlamydia is around 5%. Trichomonas is the same, 5%. Gonorrhea, 2.5%. Mycoplasma genitalium, about 10%. We do between 5,000 and 6,000 tests per month for chlamydia and trichomonas and gonorrhea with positivity rates of 2.5 to 5%. My thought is we are not testing nearly enough for MPOX virus if our positivity rates are above 20% nationwide. I'd really like us to get consistently to positivity rates of 5% or less before we start to feel very comfortable that the current outbreak is under control. So just to summarize, prior to this year, MPOX was a very rare cause of disease outside the continent of Africa. This is the largest outbreak in recorded history. It spread currently primarily through direct contact with an infected lesion or through contact with contaminated objects such as bedspread or clothing. Unfortunately, the clinical presentation can be highly variable from mild to severe, and this is what is contributing to continued spread of the virus in the population. The diagnosis is based on an individual's exposure history, their clinical presentation, and lab testing. And currently, we have good tools to diagnose these infections and growing number of commercial assays that are being authorized for use and diagnosis. Dermal and genital lesion swabs are the recommended specimen types at this point. Viral cultures shouldn't be ordered in suspect cases, and I really feel like MPOX virus is likely here to stay, at least for the foreseeable future. And I'd like to see, again, those positivity rates be south of 5% before we start to declare that the current outbreak is under control. Here's a few references that you can go to get some additional information on MPOX virus and the current outbreak. Again, want to thank CGene and LabRoots for the opportunity to discuss the ongoing outbreak with you, and I'll look forward to answering any questions you might have. Thank you.
Thank you, Dr. Binnicker, for your informative presentation. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box and click Send. We'll answer as many of your questions as we have time for. Let's get started. Our first question is, some recent reports have suggested that monkeypox can be carried asymptomatically. Is there a role for asymptomatic testing?
Yeah, great question. So obviously a lot of interest around asymptomatic testing during the COVID pandemic. And we know through a lot of studies and really strong data with COVID that the virus can be spread efficiently from those who lack symptoms. We don't know yet with MPOX whether asymptomatic transmission is a major cause of disease transmission. Now, the studies that have been done have shown that the virus can be detected from other sample types like blood, semen, urine, the throat, but at much lower rates than dermal genital lesions. So the CDC has been conducting an ongoing study looking at individuals who are exposed to MPOX virus but haven't yet developed symptoms. And those individuals are having multiple sample types collected: nasal swabs, throat swabs, blood samples, urine specimens, to see what the detection rates in various sample types look like until an individual begins to develop clinical disease. And I'm looking forward to the data from that study being published. And I think it will really inform whether asymptomatic testing is going to be feasible and useful, or whether it won't be useful as it has been with COVID-19.
Great, thank you. Our next question asks, you indicated MPVX is sticking around. When is it appropriate for testing to be part of a panel of other lesions causing pathogens?
Yeah, I think we're already at a point where, as a laboratory director, I would like to have that tool in my laboratory. In other words, having a panel of MPOX virus along with HSV, potentially VZV as a cause of skin lesions, so that we can perform that screen and rule out on different skin dermal lesions for what we've considered common causes of dermal genital lesions, and now MPOX virus, which we can include in that list. So I'd really encourage commercial manufacturers to consider panels, because I think that they would be a valuable tool for physicians and clinical laboratories.
Great, thank you. That brings me to my next question. The initial symptom in patients with monkeypox can manifest as oropharyngeal symptoms, which include pharyngitis, epiglottitis, and odonophagia. How do I send an oral sample for testing to the laboratory?
Yeah, so if a patient has lesions in their mouth or throat that a physician suspects could be due to monkeypox, it's appropriate to swab that lesion and send it in just as they would a dermal or genital lesion. That's appropriate to collect, it's appropriate to test, because as was brought up in the question, patients can develop lesions in the mouth and throat, especially after receptive oral sex, being a means of transmitting MPOX virus. So that would be the recommended testing approach.
Great, thank you. Our next question is, would that be sexual transmission in general or rather between men?
So this is an important issue to bring up and discuss. Although early on in the outbreak, many of the cases of MPOX were in the men who have sex with men population. It is inaccurate to refer to this as a disease that is specific to that population because we have seen MPOX virus infections occurring in other populations as well. Anyone who comes in close contact with an infected lesion can contract the disease. It's even still a question of whether MPOX virus should be categorized as a sexually transmitted disease or not. There are other routes that this virus can be transmitted by. We talked about contaminated fomites being a source of transmission. So while we know that this virus can be transmitted through close, intimate contact, including sexual contact, there are other routes that can result in the virus being transmitted. So that's why it's really important to be careful about the way that we talk about transmission routes with this particular infection.
Thank you. Our next question is, do the latest smallpox and MPOX vaccines cause blistering and scar formations like the old smallpox vaccines?
Yeah, I think the answer to that is no, that we're not seeing the same type of blistering as we saw with patients, decades ago who were receiving smallpox vaccines. Um, so I don't think that is as a concern as it was in the past.
Great. My next question is, would those manifestations that appear to be somewhat irregular be due to the endemic aspects of where it originated in one of those two areas in question in Africa, or would there be another reason or cause?
Yeah. So in general, infections due to clade 2, which was previously the West African, have been more minor in terms of the disease severity and the mortality rate. And that is the clade that is causing the current outbreak. And so I think that's uh, a possible explanation as to why we're seeing a range of severity of lesions, whereas clade 1, or that Central African Congo Basin clade, usually is associated with a more severe disease presentation, more lesions, and higher mortality rates. So I think that there likely is an aspect of the type, the strain of the virus that's causing the current outbreak with the, in most situations, less severe type of clinical presentation.
Great, thank you. Our next question is, why are dry swabs or those collected in VTM compatible with testing, but not swabs in UTM?
That is a great question, and we've asked that to the CDC, and it comes down to the validation that the Centers for Disease Control performed, and they've specifically indicated to performing laboratories that dry swabs and swabs in viral transport media specifically are the ones that are approved, whereas swabs in universal transport media are not considered on label for the CDC test. Um, I think that myself, along with many clinical laboratory directors, feel that there is a lot of similarity between viral transport media and universal transport media, but currently we're only accepting swabs and VTM for that reason. I think if a lab wants to perform some comparison studies and show that swabs and UTM is acceptable, that is a possibility with a bridging study. And if companies also want to develop and validate swabs in UTM, now that there's the EUA process, that opens it up for more flexibility with regards to the type of transport media that can be used.
Great, thank you. Our next question is, in September, the CDC issued guidance for concern that the California variant of monkeypox contained a mutation that affected the target PCR gene for the CDC West African monkeypox assay. How frequent is this variant? Have you seen it in samples submitted to the Mayo Clinic for testing?
Yeah, I'm glad this question came up, and there have been a number of studies and a recent publication showing that there can be instances where the virus may have a deletion present that can render certain molecular tests as unable to detect that particular variant. I don't think that the frequency is high. And fortunately, the majority of testing that's been used to date has not been for specific clades where we're seeing this deletion issue cause more problems. But instead, most of the testing is being done at the genus level, which seems to, in some ways, sidestep the deletion issue. But it's something that we continue to need to monitor. As we saw with COVID-19, there are different variants and strains in circulation, and laboratories and commercial manufacturers will need to continue to sequence these strains and ensure that the assays that they're using are able to detect these strains effectively.
Great, thank you. And it looks like we have time for one more question today. And that question is, which type of swab is the most useful for MPOX diagnosis?
So if the question is to the exact type of swab, I would refer the participants to go to the CDC website if they're sending samples to a laboratory that's using the CDC test. The CDC outlines that there are certain types of swabs, like cotton swabs, that should not be used. But dermal and genital swabs are the preferred specimen type. I know that some commercial manufacturers are validating specific commercial swabs or maybe even their own proprietary swab and transport media. So it really depends on the test as to what type of swab and then potentially transport media is going to be useful for diagnosis.
Great, thank you. And it looks like that brings us to the end of our Q&A session for today. Thank you, Dr. Binnicker. Do you have any final comments for our audience?
Just appreciate everybody taking the time to join me today for this overview of MPOX, and I hope that the rest of the year goes smoothly for everybody, and that 2023 will be quieter, and we can focus on what we want to focus on instead of emerging infectious diseases. Thank you.
Yes, thank you again, Dr. Binnicker, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Seegene Technologies, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period, will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.